speaking to you today. Thank you very much for staying to the last session. Hopefully we'll give you some interesting pieces of information. So let's start. First of all, I would like to mention that I am currently representing the Eastern Mediterranean region in the International Society of Blood Transfusion. I am working as the liaison between our region and the society. If you have any ideas or if you would like to know more about the opportunities that the society provides to individuals and other societies as well, I'm happy to talk to you about that. I'm also working with the Ministry of Health on some aspects related to the transfusion medicine or blood banking changes in the country. So what I'm going to cover today is I'm going to talk about TRALI and TACO, transfusion-related acute lung injury and transfusion-associated circulatory overload. We're going to cover the diagnostic criteria, pathophysiology, clinical features, and mitigation strategies. How can we prevent them? I will not talk extensively about a third respiratory transfusion reaction called transfusion-associated dyspnea. This is a diagnosis of exclusion if patients have respiratory transfusion complications that cannot be classified as TRALI or TACO, then it's appropriate to put them in the category of TAD. But I'm not going to talk about TAD that much. These two respiratory transfusion reactions are the leading causes of death related to transfusion around the world. All countries that have national hemovigilance system that were able to collect strong data about complications and mortalities proved now and again that TACO and TRALI continue to be the leading causes of death in patients who die as a result of a transfusion. For example, these are data of the US FDA covering 2015 to 2019. If you look at the red circle, you can see that TACO and TRALI make up to more than 50% of cases of death related to transfusion, and they are leading among all other transfusion complications. However, during this talk, and whenever you hear about incidents and rates of transfusion reactions in general, please remember, in general, we know those rates are not very accurate. The reason is professionals do not always recognize transfusion reactions. They don't always pick up that this could be TRALI or TACO or even related to the transfusion. And sometimes they do recognize that this is likely related to the transfusion, but they do not report it to the blood bank or the transfusion service for a variety of reasons. For example, this is a study that proved this very clearly. This study was performed in the United States, covering 4 different hospitals. They collected transfusion episodes, 200 transfusion episodes every month for a period of 6 months from 4 different hospitals. In total, more than 4,000 transfusion episodes were reviewed. Files of those patients were reviewed in order to identify any potential transfusion reactions and whether those reactions were reported to the blood bank. Interestingly, 39 cases of TACO were identified by the expert review. Physicians looking after those patients actually picked up that those were TACO cases in about 60% of the cases, but only a minority, only 5% were reported to the blood bank. Similarly, in TRALI, 4 cases of possible TRALI were picked up by expert review. All of them were suspected by the doctors, but only 1 of them was reported to the blood bank. So it's very, very difficult if you're relying on a passive surveillance system. We're working the transfusion or the blood bank. We're waiting for people to tell us about the cases that they are seeing, the transfusion reactions they are seeing. We're not hearing about all of them. If you work in the clinical side as a physician or a nurse, please make sure that you report any complications related to transfusion to the blood bank. Even if you're not sure they are related, the blood bank will do the investigation and determine if this is, how likely this is related to the transfusion, and also determine the type. You're not expected to know the type of the reaction when you encounter it at the bedside. So having said that, those are the data that we have in the literature. So TRALI incidence is 0.04 to 0.1% of transfused patients might encounter TRALI, which is equal to about 1 TRALI for each 5,000 transfused blood components. However, the incidence is variable according to the population studied. So if you look at this table, it summarizes the incidence of TRALI in different hospitalized patients, so in general in a hospital or specifically in the ICU. And repeatedly, we can see that the rates among patients in the ICU are much higher than among other patients hospitalized for outside of the ICU. So keep that in mind. This is the old definition of TRALI. This is the definition that we were used to. It was described in 2004. It is well known as the Canadian Consensus Conference definition, or the NHLBI definition. Basically, the definition consisted of a patient who develops acute lung injury, and the definition of acute lung injury is written on the right. So it has to be of hypoxemia, of acute onset, with abnormal chest X-ray, showing bilateral pulmonary edema. In addition to the acute lung injury, there had to be this temporal relationship to the transfusion within 6 hours. There had to be no volume overload, and there had to be no risk factors for acute lung injury. So no burn, no pneumonia, etc. So this was TRALI. In patients who had other risk factors for acute lung injury, for example, a patient with pneumonia or pancreatitis, or burns, for example, those patients, if they developed acute lung injury in relation to the transfusion, those were classified as possible TRALI. Possible TRALI was a confusing term, and then another change came that warranted a change of definition of TRALI. In 2012, a group of ARDS experts, so critical care physicians, revised the definition of ARDS. In the new definition that was released in 2012, there was nothing called acute lung injury. It's all ARDS. Patients who had acute lung injury, who were classified as acute lung injury in the past, are now classified as mild ARDS. So the category of acute lung injury is no longer present, which led to the new definition of TRALI that was described in 2019 by a group of experts. It was performed by agreeing on consensus through Delphi technique. Basically, the name TRALI will not change, although acute lung injury is no longer existent. But in the description, you will no longer find the term acute lung injury except in the name itself. So now it's ARDS. And they changed the diagnostic criteria to allow for other imaging techniques other than X-ray. Now, ultrasound is a recognized imaging technique that can be used to prove pulmonary edema, and also CT scan. So X-ray is the simplest and easiest, obviously, but if you have a CT or an ultrasound, that would be enough. The temporal relationship to the transfusion of 6 hours is still there, no volume overload, and if present, the decision must be made on the clinical side that the volume overload was not the main reason for patient deterioration. And no risk factors for ARDS. Those patients are now classified as TRALI type 1. Patients who have ARDS risk factors are classified as TRALI type 2. But they clearly describe that patients who have ARDS risk factors, the respiratory status must have been stable or improving before the transfusion. If a patient was found to be already deteriorating from their ARDS risk factor before the transfusion, then those are not classified as TRALI and are classified as ARDS. So just summarizing the change, there is no longer anything called possible TRALI. It's now TRALI type 1 and type 2. Both are reportable to the blood bank. Imaging can include CT and ultrasound as well, and the term acute lung injury is no longer used except in the name of the condition. Reminding everybody that TRALI is a clinical diagnosis. We don't do a test in order to prove it. Patients may present with dyspnea, tachypnea, hypoxemia, rigors, fever, and sometimes hypothermia, tachycardia, blood pressure changes, and interestingly, transient leukopenia and transient thrombocytopenia. we always need to remind clinicians, if you work at the bedside, please make sure if your patient develops respiratory deterioration during or after the transfusion, please make sure that the file of the patient or your notes include assessment of patient volume status, chest imaging. The chest imaging does not need to be completed within 6 hours. It can be completed within 24 hours. But the onset of symptoms must be present within 6 hours. And there has to be evidence of hypoxemia. Otherwise, with no hypoxemia, this is not TRALI. As I mentioned, there are no tests to confirm whether this is TRALI or not. It's basically purely based on the clinical presentation. However, we could use the presence of HLA and HNA antibodies, human leukocyte antigen antibodies, and human neutrophil antibodies, testing of the donor in order to determine future eligibility to donate. But the results of the antibody testing do not necessarily affect the diagnosis because antibodies are present only in 50 to 80% of donors implicated in TRALI cases. Prognosis of TRALI ranges from mild to severe. Sometimes some of these patients only require supplemental oxygen for a few hours or a couple of days and then they improve. However, 5 to 10% of patients eventually die. But if you compare the risk of death secondary to TRALI in comparison with other causes of ARDS, which is 30 to 40%, TRALI is definitely, the mortality rate is much lower than that. However, just reminding everybody, transfusion is expected to be very, very safe at this point in time. So even this low mortality rate is considered high in terms of transfusion-related mortality. The pathophysiology has always been described as the two-hit theory, where the first hit is a recipient, a patient who is primed and ready for the activation of their leukocytes. So the recipient is primed, susceptible because of an underlying condition, receiving a blood product that contains antibodies or contains bioactive lipids or other elements. So on the left side, you can see a list of conditions that are considered first hit. All of them share the fact that interleukin-8 is high in these conditions, including sepsis, pneumonia, cardiopulmonary bypass, burns, pancreatitis, etc. And then when a blood transfusion is given containing those antibodies, primed white cells are activated and then pulmonary edema occurs. However, the two-hit theory could not explain why TRALI sometimes happened in otherwise healthy individuals, patients receiving a transfusion in daycare, for example. And that's why the threshold model came out. Basically, the threshold model tells us that some patients, healthy patients who are not previously primed, do not have a first hit, might have TRALI if the level of the antibodies administered, infused, was very, very high. The titer was high enough to cause them symptoms even if they were not susceptible in the beginning. In patients who are primed and who have the first hit, a lower level of antibodies might be enough to cause TRALI in these patients. Role of platelets is very interesting. As you noticed, I mentioned that some patients have transient thrombocytopenia at the time of the reaction. And this led to an investigation of the role of platelets in TRALI. And it was found that platelet sequestration in the lungs was observed in animal models. And this phenomenon was dependent on the presence of neutrophils. And platelets and neutrophils aggregated in blood vessels and around alveoli. In animal models as well, platelet depletion protected animals from lung injury. And aspirin use was helpful in improving survival. This was not reciprocated in humans. There was one study, a case control study of 109 TRALI cases, which is a lot. Aspirin was not protective. Another interesting phenomena that is seen in TRALI is netosis. Netosis is a method of cell death, similar to necrosis on apoptosis, where a white cell tries to perform its antimicrobial activities by releasing DNA as a form of a net. And as you can see in the illustration, it captures bacteria this way. So nets were found in patients with TRALI. They increase endothelial permeability, and it's an event that is very fast after antibody challenge. In animal models, aspirin not only affected platelet function and role in TRALI, but also blocked net formation. And interventions targeting nets, so affecting the DNA itself, reduced complications of TRALI and improved survival in animal models. We still don't know whether this would be helpful in humans. Risk mitigation is the biggest thing in TRALI, and given the understanding of the pathophysiology and the role of HLA and HA antibodies, helped blood bankers tremendously in improving the management of blood donors. First of all, we should all agree that the proper use of blood components is the first line of prevention of transfusion reactions. And as we always like to say, the best transfusion is the appropriate transfusion. And then we come to the elimination of high-risk donors. So donors who were implicated in cases of TRALI, donors who are known to have HLA or HNA antibodies, and donors who are at risk of having HLA and HNA antibodies based on the risk of pregnancy. All of these are managed differently. And why is that? That's because the prevalence of HLA antibodies was studied in the general population. So if we took men and women with no previous history of pregnancy, the risk of having HLA antibodies in these individuals is less than 2%. Transfused men versus non-transfused men are not very different. So the transfusion per se is not a significant risk factor of developing HLA antibodies. However, pregnancy was found to be a significant risk factor for having HLA antibodies, and the percentage depended on the number of pregnancies. So women who were never pregnant before, as I mentioned, the percentage of those with HLA antibodies is less than 2%. The more pregnancies, the higher the percentage of women with HLA antibodies. Even from one pregnancy, it's more than 10%. And that's why women with a previous history of pregnancy are no longer accepted as donors of plasma or platelets, apheresis platelets. The ABB standards clearly mention that plasma and whole blood for allogeneic transfusion shall be from males, females who have not been pregnant, or if a female was pregnant, she should be tested after their most recent pregnancy and shown to be negative for HLA antibodies. So deferral of donors implicated in TRALI increased the safety of red cells, platelets, and plasma. Limiting donation of plasma and apheresis platelets to male donors and women who are not at risk of developing HLA antibodies increased the safety of platelet and plasma transfusions. Also, suspending whole blood-derived platelets in male plasma or platelet additive solution further increased the safety of platelets. And finally, the use of solvent detergent plasma from plasma fractionators, diluting any antibodies that could be in plasma, was very helpful in reducing the risk of TRALI from plasma even further. So this is a beautiful graph, I really like it. It shows how the incidence of TRALI secondary to plasma dropped significantly after the implementation of risk mitigation strategies. So it was between 3.2 to 3.6 per 100,000. This is according to one center, the New York Blood Center, and significantly dropped to 0.4 per 100,000 after use of male or females who were never pregnant. The risk of TRALI from red cells and platelets is still there, and further action is being performed, including use of filters that might block the passage of antibodies. But this is still out there. So changing gears to TACO. And TACO stands for transfusion-associated circulatory overload, a transfusion reaction that personally I have seen during my internship and residency. I never paid attention. This was, to me, at that point in time, simply volume overload, like any other volume overload. Nobody needed to know about it. The patient improved with diuretics, and things stopped there. We now understand it is way more serious than this. So this is there are multiple definitions for TACO. I'm just showing one of the important ones developed by the ISBT in collaboration with the International Hemovigilance Network. And this definition contains 5 criteria. The first 2 are, we need one of the first 2, and they should occur within 12 hours of transfusion. So there has to be an element of respiratory compromise by symptoms, for example, and evidence of worsening pulmonary edema based on physical examination and or chest imaging. In addition, we need a total of 3 criteria, so one of the first 2 or both of them in addition to something from this list of 3. So cardiovascular system changes, including vital sign abnormalities, hypertension, tachycardia, jugular venous distension, enlarged cardiac silhouette, or peripheral edema. Evidence of fluid overload, for example, positive fluid balance, or the patient improved after diuresis.
5 minutes, please.
Okay. And results of relevant biomarkers. Biomarkers used in TACO assessment basically are BNP, a beta-natriuretic peptide, and N-terminal pro-BNP. They are not very helpful in critically ill patients because they are high at baseline. In non-critically ill patients, if the levels are low, it can be used to exclude TACO. The incidence is considered around 1 in 9,000 transfusions, 1% of low-risk patients, and 12% of high-risk patients are at risk of developing TACO. There is another 2-hit model with a threshold model as well for TACO, where a patient is predisposed to TACO because of cardiac condition or liver or renal disease, or positive fluid status, and then receiving a high volume of blood resulting in TACO. Also, a previously healthy patient could also develop TACO if they received lots of blood products at a very high rate. So a summary of the clinical evaluation in these patients: if we encountered a patient with respiratory compromise thought to be transfusion related, we need to exclude anaphylaxis and allergy. If the patient had pulmonary edema on chest X-ray or examination, then this could be TACO or TRALI. We would evaluate their physical status, cardiovascular examination, evidence of volume overload, and assess their fluid status. If these were abnormal, then this is likely to be TACO. If those were not there, then this could be TRALI. And if it's not TRALI, then it is transfusion-associated dyspnea. This is the TACO checklist. This is promoted by the SHOT, the Serious Hazards of Transfusion, which is the hemovigilance body in the UK. They recommend the use of this checklist before every single transfusion in order to assess if the patient is at risk of developing TACO because of their cardiac or renal condition. And in these cases, the physician is asked to reconsider whether the transfusion needs to be given or should be given slowly or at smaller volumes. So just to summarize, hypoxemia is necessary for the definition of TRALI type 1 and type 2. It's not necessary for the definition of TACO. Pulmonary edema on imaging is necessary for the diagnosis of TRALI, but not necessarily for TACO. The onset within 6 hours is within the definition of TRALI. Some definitions of TACO say 6 hours, some say 12. Risk factors of ARDS are necessary to say this is TRALI type 2. And of course, volume overload or left atrial hypertension is necessary to make the diagnosis of TACO. So to conclude, updated definitions of TRALI and TACO are available. We need to use them. Respiratory transfusion reactions continue to be the leading causes of transfusion-related death. If you're using BNP or NT-BNP, those are not very helpful for diagnosis of TACO in the ICU, but can be helpful to exclude TACO if the levels are low in patients out of the ICU. And better understanding of pathophysiology of these complications led to effective mitigation strategies for TRALI, not very much for TACO, but hopefully in the future. That's it, and this is my email. Thank you.